This is the Live Wire on Inside UNC Charlotte, and we welcome you and thank you for putting us on your screens. And in this segment, we're going to have a discussion about a topic that is ever present in news and daily conversation. The topic is Ebola. And what we're going to do right now is have a conversation that we will attempt to focus on the medical aspects of Ebola. And our guest is Dr. Robert Jones, who is the Medical Director of the Student Health Center. And first of all, Dr. Jones, thank you for being with us.
It's my pleasure.
And also in the course of our conversation, as we try to do on these editions of the Live Wire, we'll maybe get to know the Student Health Center a little bit better too, and what you do in your role that is essentially the university doctor. So,
Indeed.
Recently on campus, there was a panel discussion with a group of faculty members talking about various aspects of Ebola, and we thought it would be important to add to the ongoing discussion your perspectives from the medical field. And let's get started first with a statistic. Here in our region, Mecklenburg County Health Department says that it is monitoring, as they put it, fewer than 10 individuals who may have been exposed to Ebola. Is that the right way to put that? And
Well, yeah, I think that the way I understand it is these are people who have traveled from index countries where there is some, where they may have been exposed to the Ebola virus in people that they've come in contact with, but show no symptoms at this point.
now we feel such a need to be careful about how we refer to these things. Did I just make a mistake by saying may have been exposed? They were essentially on the ground in an index country, as
That's
you
correct.
say. And we're going to try to steer clear of those the political and sort of the things that some folks might call hysteria. But at the same time, at a university where we have any number of students who may, for any reason, be traveling in the world. We have faculty members and staff members who, for any reason, may be traveling in the world, and we bring guests to our campus who may be coming from other places in the world. In fact, on a daily basis.
Indeed.
That creates a situation that even within Mecklenburg County, we are unique, we stand out, we have some issues that we have to be maybe aware of and concerned about on a more intense level. Is that fair to say?
It is. It is. I think that it's Charlotte having an international airport, being a major city in our country, and having a major university like this, I think will attract the types of people that you talked about. Our students, we have a very robust international student population here. We have faculty members that travel internationally and are from countries around the world, and then we bring in speakers from around the world. And so because of that, I think that our the way that we approach this, I think, has to be commensurate with that. That we sort of that we're aware of all the people that are coming to campus, and then make decisions about what we do on campus with that in mind, so that we don't expose the campus unnecessarily, but that we also don't create unnecessary hysteria around it.
What is your role in that process, and what is the role of the Student Health Center in that process?
Okay. I think that my role and the Student Health Center role, I think, are combined there. The Student Health Center's role really is in the evaluation and treatment of, or evaluation, processing and treatment of suspected cases. You know, the Student Health Center is not in a position to be able to treat in any definitive way those patients, but it really is in identifying someone who may be at risk and identify them as a suspected case, and then move them along the process to get definitive care. My job as the medical director is to be the medical consultant for our small town of 27,500 people, so that we're in the guidelines that we set up and in the ways that we approach this disease process, that we are mindful of the risk out there and mitigate it appropriately without creating undue hysteria. So I give input and information to the campus at large about educating the campus on what this really is, how it's really transmitted, and then what the risks really are, and then try to mitigate those.
What kinds of things are you hearing from folks who come through the doors of the health center, students and other people? And do you hear anything? Do people say, gee, what's going on? Are we at risk of Ebola on campus, that kind of thing?
Not very much, which I think is a good thing, that we don't have people storming the doors saying we're afraid. I think people are asking. We have signs up at our doors asking the students when they come in if they have traveled outside the country within the last 3 weeks and they have symptoms or they've been exposed to somebody that they knew had this, that they let us know so that we know going in. We can enact the appropriate protocol for that. But we have a few people that come in and ask just informational questions. They just want some education about this. I've been hearing so much about it, but I don't really know much in terms of details. But not a lot in terms of people coming in thinking, could I have this? Is it possible that my roommate might have it? I saw somebody in the library the other day coughing or looking ill. Could they have it? There's not a lot of that fear. At least we haven't heard a lot of that. But we do have people, a few a day that come in and ask questions about it.
Sure, and that's good to know. Let's take a look at the web real quick, and we won't go into a surfing session here, but let's just start by pointing out that the Student Health Center does indeed have a pretty detailed website, and you see over here there's a link to Ebola information, and it's my understanding that will continue to evolve as we go along, and we'll be putting even more information out there about Ebola and about the issues that pertain to the community that you describe, a university community with all its unique facets. And let's take a look here at this is just to point out, and hopefully our audience will go back and take a look at these sites after our discussion. But Mecklenburg County has a pretty comprehensive site as well, with good information and facts you need to know about Ebola, and again, getting more localized and things we need to know here in our region. And then sort of the Ebola Central here in the United States is the Centers for Disease Control and Prevention site. And again, you'll notice that ends up being sort of a /Ebola address there over here. But for folks who are taking a look at this, this is worth checking out. And it's also, as I think you are quick to note, it's something that changes in some cases every day when it comes to the available information and our interpretation of the available information. How does this sort of evolution of awareness of Ebola, and again, Ebola isn't new, but we're in the midst of what most experts are clearly calling the worst situation on an increasingly global scale. How does this stack up with recent other medical pandemics or near pandemics or other crises in the world? For instance, some folks say Ebola might be the new HIV, or some folks say, remember H1N1 and how prepared we were for that, and in the end, H1N1 didn't necessarily sweep us like we were prepared for. So
thankfully,
how does Ebola stack up with what you've seen in your career and what you've seen in the study of medical history?
I think that it's interesting to note, or important to note, that the Ebola virus has been around for almost 50 years. Its first iteration was in 1976, and so it is not new, as you said. And we've had several Ebola outbreaks over the years, none quite as bad as this. So this you are correct in saying this would be the worst. I think the thing that scares people is the death rate of this, that somewhere around 56% of patients with the Ebola virus will succumb to that disease. And I think that scares people. It's sort of an unknown.
But do you think as a physician that data, the numbers are skewed somewhat because of the fact that it's occurring in developing countries where the medical treatment is not as readily available?
Absolutely. And I think that the panel the other day did a very good job of laying out that case, that there's, one doctor for however many tens of thousands of potential patients in some of these countries. And so the medical care, that medical care net is not nearly as broad or as strong, sturdy to be able to manage that. I think that that's absolutely correct. But I think if you look at the actual numbers, the numbers are still small. If there are upwards of 15 million people in the three index countries, and 10,000 cases at this point, I mean, the numbers are still relatively small. Yeah. I think that so as it stacks up, when it affects people, it affects them in a significant way, but it doesn't affect that many people. So it's a little bit more difficult than other illnesses or other pandemics that we've had. It's a little bit more difficult to transmit. It is not easily transmitted, which is something we can talk about later. In the way, and I think that's one of the things as it stacks up. They're probably, I think it's a true statement to say that there are probably, or for sure, more people that will be affected by influenza this year, and the risk of dying from influenza this year is higher than the risk of dying from Ebola this year in the United States. And so I think we have to keep those numbers in perspective when we see them. The death rate is is fairly high for this, but it doesn't infect that many people.
And of course, the media become a factor, and we see with news cycles, and the few cases in the United States that have resolved, or one case sadly. That feeds a sense that it kind of comes and goes and has ups and downs. But you're right. I think that essentially 50-50 chances is part of what feeds our fears. But it's not a disease with which we've become, not sure what the right word I want to use here is, but accustomed or mentally comfortable to just kind of say, oh yeah, I'll get my flu shot, or I won't get my flu shot. I'm not worried about the flu.
Right.
Who knows if we'd ever get that way with Ebola? But at the same time, like you say, we conveniently put somewhere even outside of our mind that 30,000 people die from influenza each year. That's a lot.
Somewhere there.
Yeah.
Right. And so I think that risk is a lot higher, and that's why we really spend a lot of time and energy trying to get that information out to get people vaccinated for influenza, because you're much more likely to get that. Yeah. And for people in the appropriate circumstances, older in age, or their immune system is compromised in some way, much more likely to die from that than some of these other things. The other thing that I think is very interesting, and it's part of, I guess, trying to understand our psyche. There's also something about it being in Africa. We don't know as much about it as we do about influenza. We hear about influenza all the time. But there's something about it being in small countries in Africa that creates something mysterious about it.
Sure.
So if there's a case in a country in Africa, there were only 18 to 20 cases, something like that in Nigeria. But then Nigeria was one of those countries that we said, okay, we don't want to bring those people here. And there was a college in Texas that was sending rejection letters to Nigerian applicants. But yet, the state of Texas, arguably the size of a small country, had 3 cases, but we wouldn't say, let's not let somebody from Texas travel to our state. Yeah. There's a psychosocial piece to this as well, that we're willing to ban some folks, but not ours.
And Nigeria has a huge population, and Nigeria is now off the list of index countries. Absolutely. What'd they do right?
Absolutely. Well, I think their physician to patient ratio is a lot higher, and so and I think what they did really well was that they got out in front of this. I mean, they got people out early. They spent money to get information out, and then they did upwards of 20,000 home visits of medical professionals going to homes, checking people. And so I think that they were able to get out in front of it in a very proactive way, whereas unfortunately, because of the ratio of doctors to patients in some of these other countries, they didn't have the manpower to get out in front of it in that way, and so have had to become more reactive in their approach to it.
All right, well, we're talking with Dr. Robert Jones here on the Live Wire, and we're talking about Ebola from a medical perspective and from the perspective of the UNC Charlotte community. And let's touch base on a point you promised a few minutes ago to address. Let's talk about the nuts and bolts of Ebola.
Mm-hmm.
It boils down to it's a virus. Mm-hmm. How does it spread? What do we do to avoid it?
Mm-hmm. So Ebola is there are 5 species of the Ebola virus. This is a particular species. Some of the others have been part of outbreaks in previous years. This is 4 of those species are in humans, 1 is not. This particular virus is passed through direct contact with body fluids. There's no evidence that it is aerosolized or passed by respiratory ways, and so it will infect someone and create characteristic symptoms. So those symptoms are fever, headache, abdominal pain, nausea and vomiting, diarrhea, muscle aches, and so you might say, wow, those sound fairly non-specific symptoms. You might get that any day in the wintertime. Yeah. The other piece of that is that it would be in the context of having traveled to an index country or coming in contact with someone that you knew had the virus. So with that, and so there's 3 main questions actually that we're asking to be able to get at that information is, have you traveled to one of the index countries within the last 21 days? Have you, that you know of, been in contact with someone infected with the virus? And do you yourself have any symptoms? Those are 3 main questions that all healthcare professionals and public health officials are looking for from patients that we're evaluating as suspected cases or not. So those are the characteristic symptoms. It really is not passed by casual contact. This is direct contact.
So it's unlike influenza.
Indeed, indeed.
Okay.
And so just being on an airplane with somebody who had it would not put you at risk. Just being in the room or the same building with someone who had it would not put you at risk. And one of the things that I think speaks to that is the fact that the close family of Mr. Duncan, the index case of Ebola in the United States, were in the apartment with him for at least 2 days while he was actively symptomatic, and they never tested positive and never were infected with the virus. And they were in direct contact with him in a small apartment. And so I think that really does sort of highlight the fact that it's not very easily transmitted, that you really do have to come in contact. So the 2 other cases in the United States where the Ebola virus was transmitted were in healthcare workers who were working directly with this gentleman, and touching his bodily fluids and doing the things that they need to do for their job. That's how it's done. So it's that those bodily fluids getting on mucous membranes or even on skin is how it's transmitted. There's no specific treatment except supportive treatment. So there's no antibiotic for it or antiviral medicine for it. It's supportive treatment. It's oxygen, it's IV fluids, it's keeping them from being dehydrated. They've done some work with dialysis and some other ways of treating it. And they've used the serum, the antibodies from Ebola patients, the American Ebola patients that have survived this infection, using their antibodies to help other patients fight that off, and they've been successful in that. But those are sort of the sort of nuts and bolts of the virus and the infection itself.
So going back to something that we talked about at the beginning of our discussion, the characteristics of a university community such as ours, as you say, 27,500 students, plus another several thousand faculty and staff members and people coming and going at all times. The way you describe the transmission of Ebola still, for the most part, would seem to be a tall order to say, well, you know, a university campus like ours is somehow, you know, at risk of, once it's on campus, look out. I mean, and I'm not saying that to be silly or to reflect some sense of hysteria about this, but we have students who live with one another in residence halls on this campus. We have a lot of parents and families who are very concerned about their students 24/7, and that's something that I think we always have to factor in, and that's not to at all suggest that you know, the parents and families of our students and our university community are poorly informed, but I think you must sense, as the doctor of UNC Charlotte and with your staff, even if we weren't even talking about the occasional questions about Ebola, the concerns about what the safe environment on campus when it comes to illness has to be kind of intensified, isn't it? Or,
indeed. And I think that it starts with identification. I think that screening people to identify people who might be at risk and then getting them the appropriate resources is how we would approach it here. I think that overall our risk is relatively low for this, but I think that we have to have a robust effort in screening folks, identifying people that might be at risk, and then isolating them and getting them to the appropriate resources. And so our approach as a health center is a stepwise fashion, a way of doing that. We, like I spoke about before, we have posters or signs on our doors for anybody coming in to say, if you meet any of these criteria, let us know. That doesn't mean anything bad. It's not, we're not going to lock you up or anything, but then we'll take a sort of a heightened investigatory approach to answering some of those questions, really looking into where you've been and who you've been in contact with, and then in the appropriate situation, getting you in contact with public health officials here and to more definitive treatment.
We're having this discussion at the end of October in 2014, and it's safe to say that from the data that we see that the disease will continue to spread at some kind of pace that could have it, you know, some much larger numbers by the first of the year. And it's also safe to say that here on this campus, the conversation is going to continue, and some of those other aspects of readiness and preventative measures and just discussion and information are going to be happening at the faculty level, at the staff level, those who travel, students going home on winter break. I mean, I assume that we're not necessarily tracking anybody likely to travel to index countries, but then again, what are we doing from your perspective to communicate campus-wide, or are there things we could be doing better to say, if you're going anywhere, let us know, and this is not meant to create a threatening environment, but it's just common sense.
Indeed, and I think, you know, the CDC has a travel advisory for travel into those identified countries that's worded as non-essential travel, would be discouraged to those countries. We don't. I think getting information out, and as we get closer to the holiday breaks, we'll start to push more information out to people, just making them aware of what the risk is of traveling to those countries. We understand that there are students that we have here whose homes are in those countries, their home of origin, and so we want them to have that information as they move forward. We will also do our best to try and identify people who might have opportunity to travel to those countries. But this is taking a sort of a coordinated university-wide effort to try and identify people who are potential study abroad candidates who are doing research in some of those countries, or who, for humanitarian reasons, want to travel to those countries as part of other humanitarian organizations, that we try our best to try and identify those people so that we have an idea when they come back of who we need to pay attention to. Because what the CDC's directive and public health officials' directive may be 2 months from now, may be very different than it is today. And so
Sure.
we want to have some way of being in contact and being aware of who might have traveled there. And I think the same is true for the faculty, for faculty that may travel over the holidays to be a visiting professor or to do humanitarian work, that we ask them, all of these students and faculty, to identify to us that they may be traveling to these countries for their own good, so that we can sort of monitor them, we can be aware of this and monitor them when they return, and that they're not sort of holed away in their own home without anybody knowing.
Sure.
But all that's being developed at this point. So the campus has a campus-wide committee that is starting to put together some coordinated efforts about how we will track creating a travel registry for faculty members, and how we will track people who will travel to these index countries, and then monitor them when they come back.
The health center on campus is a multifaceted, multi-service operation, and in your area, in the medical services, can you give us any data, maybe off the top of your head or your firm working knowledge? How many patients do you see a week? What kinds of what are some of the common things that students are coming in for, if that's something that can be divulged?
Sure. I think that we see a lot of bread and butter things. So we see a lot of respiratory illnesses, cold symptoms, urinary tract infections, musculoskeletal injuries. We have a lot of our students play intramural sports,
Sure.
And do things outside of school. And so there are a lot of scrapes and breaks and strains that we see. We see all manner of the usual, I guess, primary care thing. We see sexually transmitted diseases. We see common infections. We see dermatologic issues, rashes.
Do kids still go off to college and get mono like they used to in the old days? Is that?
They do, as a matter of fact. Although we see more and more have had that particular virus prior to turning 18. But we do still see that much because, again, these are 5,000 or 6,000 students on top of each other in dorms, right. And so those kinds of things will still happen. But we also have a very diverse student population. So our student population is not just 18 to 25.
Sure.
We have 18 to 65-year-olds, and so we see some of the ravages of chronic diseases in our patients as well. So we do a fair amount of chronic disease management: diabetes, hypertension, hypercholesterolemia, thyroid disease. We unfortunately diagnose several cases of cancer each year. And so what we talk about a lot is being prepared to see anything, understanding that we will see a lot of the bread and butter illnesses of primary care, but being prepared to see any and everything, because we do have a lot of second career students, people who are coming back to school at age 40, 50, 60, and the things that will befall that population of patients we have to be aware of as well.
It's a great asset and a great benefit of our university community to have, as I said, so the multi-featured health center. There are lots of other areas that are non-medical, but are part of the health center as well. And,
absolutely, and I tell people all the time that one of the things that I really like about the health center is that it really is sort of a one-stop shop. We have X-ray on site, we have a full-service laboratory on site, we have a full-service pharmacy on site, we have physical therapy on site, and so it is not at all uncommon to see someone, send them to the lab, write them a prescription, that they get at the pharmacy, refer them to physical therapy, and all that happens before they walk out of the door. And so we really do have the resources to manage a wide variety of things.
All right. Well, I have a feeling we'll have some more discussions as the academic year, and who knows how much into the future, particularly with Ebola, but other issues as well. But for now, we want to thank our guest, Dr. Robert Jones, who is the medical director of the health center here on the UNC Charlotte campus, and for advancing our discussion on Ebola, which is something that is going to be part of this year at least for sure. And
no doubt.
We'll be watching the data, and maybe a recommendation is for those of us who want to be informed, let's find the sources of the data and maybe make some of the news coverage secondary.
Indeed.
So,
indeed.
All right. Well, we appreciate
Facts
you.
and evidence.
Yeah, we appreciate you coming by on the live wire, and look forward to having you again.
Thank you for
All
having
right.
me.
Good. Thanks.
Mm-hmm.